Thank you, organizers, for inviting us and giving an opportunity to discuss a rare case, either a rare histology or a rare setting. So basically, we've not gone in for a rare histology this time, but a very, very unique situation that we were in just some time ago when we faced this particular patient. I have Dr. Maneesh here who would present the case, and then we would take the discussion from there.
Thank you, ma'am. Good afternoon, everyone. Thank you for this opportunity. Starting with the case, our patient is a 29-year-old lady with no children. She has no comorbidities or any family history of malignancy. She presented to us at 10 weeks of gestational age at presentation with the presenting complaint of a right breast lump and headache since 1 month. At baseline examination, there was a right breast lump measuring 4.5 by 4 cm in the upper inner quadrant with no axillary or supraclavicular lymph nodes. Her ECOG performance score was 1. Her general condition was good. Neurologically, she had complaints of headache, diplopia, with no focal neurological deficits. She had an ultrasound of the abdomen pelvis done from outside, which confirmed a gestational sac. Over to you, ma'am.
So this is seemingly a lady with early pregnancy-associated breast cancer. So, and also with suspect brain metastasis from breast cancer. So I just wanted to ask from our panel, Dr. Shalaka, how would such a patient be managed when she walks into your clinic? Is Shalaka there?
Yes, Rima. Hi.
Hi.
So clearly she has symptoms of metastasis. So you need to evaluate that. Some imaging. So we'll have to offer her some imaging for the brain metastasis symptoms that she has. So between CT and MRI, I will leave it to the radiologist what is safe to do in the first trimester, which contrast is safer, whether contrast can really be offered in this situation, especially an MRI would be what our first choice of investigation for a brain met would be, but whether that can be done in pregnancy. Other than that, in investigating for the symptomatic brain mets, we will have to look at her, as you are saying that it looks like an operable breast cancer situation. Because it's a less than 5 centimeter tumor and no axillary lymph nodes. So this looks like an early breast cancer, largish maybe, but early breast cancer. So we will have to do an ultrasound of the breast. If required, a mammography may be allowed. She's 10 weeks and a core biopsy to prove the diagnosis, and we'll take it from there. If the brain met is proven, then she will require rest of the metastatic workup as well, whatever can be done in the first week of a first trimester. And then we will also find out from her how keen is she on continuing the pregnancy, etc.
Right. So I agree completely over there. And this is how we would anyway proceed. The thing I would tell is that mammography is safe in any trimester. The doses from mammo are very, very low to the embryo or to the child. And therefore, mammography should be done in a patient where you think you want to conserve breast. So,
Rima, there is, at that age, and at that density probably, and the pregnancy associated changes in the breast, an ultrasound becomes a useful adjunct because the mammography may not be.
Obviously. So similarly, we moved on and we have to decide a few things up front. So there are these questions in a patient that comes to our OPD. One is decision regarding gestation. We have other medical oncologists. Dr. Atul Batra, would you want to weigh in on something like this? Would you at this point in time talk about gestation? Whether to go ahead or not?
It is more of a prolonged discussion with the patient that what exactly the patient is willing for and what is the kind of, I think the investigations, what are they revealing? We should first have the, I think, complete staging workup done with an MRI, brain and chest X-ray and ultrasound abdomen, and if needed MRI thorax and abdomen, including spine, and also a biopsy, what kind of a tumor it is, if it is a triple negative tumor, and then we'll get an idea of what kind of prognosis are we looking at. That will help the patient also to make the decision. But the decision would primarily be driven by what the patient wants rather than
correct. That's an excellent point there. So can I bring in Dr. Purvi Harya? She's a radiologist on the panel here. And Purvi, if you can speak to us about the safety of all these investigations that we've just spoken about during pregnancy, especially in the first trimester.
Yes. So about this patient, so now this patient has a breast lump and a suspected brain metastasis. Now we need to evaluate what is happening in the breast and in the brain. In this patient, I would first do a ultrasound, confirm the mass, but I would also want a mammogram in this case because I want to see for the calcification if there is any microcalc because that will change the extent of the surgery, which we will need. Mammogram gives a very, very low dose of radiation. It is 0.4 millisieverts to the breast, and to the fetus, it is much more lesser. So I would go ahead and do a mammogram, but first with the first ultrasound, then mammogram, and then if an ultrasound guided core or biopsy from the primary. About the brain lesion, I would do a MRI, non-contrast MRI for her first to see if to see the lesion, to confirm the lesion. Uh, Contrast MRI is contraindicated. Contrast should not be MR contrast should not be given in the pregnant ladies because the gadolinium is known to cross placenta, and we can and there are in animal studies they show effects in terms of organogenesis effect in the fetus. So this MR contrast is to be avoided. If at all we need to do a contrast, we can go ahead with the CT contrast because CT contrast does not cross the placental barrier. But we really have to weigh before we go ahead with the contrast imaging. Non-contrast, yes, we can go ahead.
Thank you, Purvi. Now, can I also bring in Dr. Sneha Shah to comment on the safety of doing a PET scan or a bone scan? Because in a patient who probably has brain mets, you would want to do a complete metastatic workup in her. And would we be able to do these investigations?
So, doing a PET scan is not indicated in a pregnant woman. But like if you have decided and discussed with the patient, if the patient says that she's not going to go ahead with the pregnancy, then yes, PET will act as a one-stop shop because you can include the brain, though brain PET scan is not very significant for picking up very small brain lesions. If you find one or two large lesions, then you could just go ahead with a PET scan to evaluate the bones, the liver, as well as the lungs if you're doing a breath hold CT together. And in this case, it will work as a imaging all the organs for metastatic at one time. But if the patient or the investigation or the person wants to continue with the pregnancy, then maybe a bone scan would be a better choice to go in because bone scan does not have that much of radiation as much as a CT component of the PET would have. So it all depends on what exactly you are planning, the patient as well as the physician decides to do with the pregnancy. If the pregnancy is not going to be continued, then I think the PET scan would be a very good modality to work the patient up.
Because do you think in the first trimester also a bone scan is feasible?
Yes, it does not have significant radiation more because anyways you have to evaluate the bones. Plus, if the patient takes care of hydrating well, then the radiation level in the body after 2 or 3 hours is not very significant to cause that much effect. There is a component of the excretion through the urinary bladder and radiation being given to the fetus. But if the patient continues to hydrate and continues to have water, then the radiation effect is not significant.
I agree with that. So now, Purvi, I want to bring you in again. In case this lady continues with her pregnancy, what is the role of a whole body MRI for metastatic workup? Do you think that is a good option? Does it help?
Yes.
Is that a better option than just doing a chest X-ray and an ultrasound?
Yes, that would be a better option than doing just a chest X-ray and MRI because it also gives us a cross-sectional imaging of the chest, entire abdomen. We can also screen the brain. We can screen the spine as well for the bony metastasis. So it's a good option. Yes.
Okay. So excellent discussion so far. I want to bring in Ayushi over here. Is Ayushi with us?
Yeah, hi Rima.
Yeah, hi Ayushi. So are pregnancy-associated breast cancers histologically different? Do we have any information from our own institute, from outside institutes?
Yeah, so first of all, before I launch into how the pregnancy-associated breast carcinomas are histologically different, I would like to point out that when we are sending material biopsy or specimen for histological evaluation in a patient who is pregnant or lactating, it was very important to first mark on the requisition form or in the EMR that this patient is pregnant or lactating, because when we are assessing such biopsies, this information is extremely useful to us. There are a lot of changes going on in the pregnant breast and the lactating breast, which can be confused with malignancy many times. Patients might have lactating adenomas or fibroadenomas that have increased during pregnancy and may undergo infarction, so the biopsy may be necrotic. We need to know all these information. There may be the ductal lobular units, very hyperplastic, and they also may show mitosis sometimes. So to first of all, to differentiate whether we are actually seeing a malignancy or not, this information is useful when we are interpreting the slide. Now coming back to
I
your
think that's an excellent point brought out, and I think all the juniors and the surgeons should take a point. And I saw Shalaka also nodding vigorously when she brought this point up. So I'm glad, Ayushi, that you brought this.
Yeah, so it actually helps us a lot in diagnosis, because when we see such changes, we are usually running backwards and trying to find out that sometimes if we look at the age and then we think that, okay, could these changes be explained by pregnancy, and then we go back. Suppose we are not able to do that, suppose we are not able to get that information in time, it is very helpful to have that information upfront so that we can make a correct interpretation. Now coming back to your question of how they are histologically different. Yes, definitely, pregnancy-associated breast carcinomas are histologically different in the sense that clinically, of course, they are higher stage, and pathologically also they are higher stage with larger size tumor, more nodal metastasis.
Recording stopped.
But when we
Recording in progress.
most of them are invasive breast carcinoma of no special type. Majority of them, more than 90%, and things like the rare variants like ILC or mucinous, etc. morphology, they are described very rarely, only as case reports. Most of the time, they are IDC of no special type. Then also they are high grade. Majority of them of the IDCs will be high grade, and the associated DCIS is also usually high grade. Coming to the biomarker profile, most of the pregnancy-associated breast carcinoma are more frequently triple negative compared to the non-pregnant population and HER2 enriched. The hormone positive is actually quite less, and if the patient is hormone positive, it is more likely to be luminal type B with more mitosis and higher MIB labeling index. So,
And Ayushi, I think this is
Recording in
also
progress.
this is also corroborated in our own series
yes,
that was recently published, that
Yeah.
we have higher triple negatives and higher HER2s. I mean,
Yeah.
a lot of it can be also a bias because we are a tertiary cancer institute, so referral bias is always there. But even then, I think series from across different parts of the world also sort of weigh in and say that this is probably seen, and they are biologically a little more adverse as compared to the general population of that age.
Yeah, in our series, we have seen TNBC forming approximately 40% of this population. In international series, there is definitely enrichment of TNBCs. 30 to 35% have been reported in international series. And
Right.
also an interesting point, actually, I would like to highlight is that the TNBCs in this population are usually have in some recent series, they have shown more presence of tumor infiltrating lymphocytes and more PD1 and PDL1. So this is a point I would like to highlight, that this particular population, they are more often TNBCs, and in the TNBCs, you are more likely to get these kind of features, which might be helpful for our medical oncologists.
Yeah, I think it's an excellent point you've brought up, and this is what we'll probably also discuss moving on during her management. So just moving ahead with what happened, and here I would like Maneesh to take over again.
So she presented to us with outside the non-contrast CT head, which revealed a 2.9 by 2.7 cm left parietal space occupying lesion, and with a considerable midline shift. Subsequently, the question that we beg to ask is that which MDT would be safe for this lady? and how to approach the medical decompression.
So we would like Dr. Bhargavi, is she there? And also, Purvi, are you satisfied with this particular imaging, or you would want an MR to confirm whether this is brain metastasis? It looks like in a non-contrast CT also, there is probably a hemorrhagic cystic sort of lesion.
Yes, I agree. It looks like an hemorrhagic cystic lesion in this setting, but if at all she is continuing with the pregnancy, I would still get a non-contrast MR done for this lesion. We might pick up some other small lesions somewhere else which are missed on CT scan. So is it a solitary lesion or there are multiple lesions? That we will be better seen if non-contrast MRI then compared to non-contrast CT.
So in the absence of a contrast agent, which sequences, would you do any special sequences to try and see, or just T1, T2 and your diffusion images are okay?
So there are no special sequences which are done for the pregnant patient. It is the full protocol MR, but it is the multiplanar MR with the where we can see whether this is in terms of gradient or SWI images with T1, T2 flare images and diffusion. We will get little more information compared to a plain CT scan. So if she's continuing the pregnancy, definitely a non-contrast MR will help here.
Okay. So is Dr. Bhargavi around?
Yeah, yes, there. So
Yes.
coming to the medical decompression therapy, so here mannitol should be avoided because she is a pregnant lady. So drug of choice will be the dexamethasone. So because it will decrease the vasogenic edema, and because it is preferred because of its more CNS penetration and less mineralocorticoid activity. So and here a patient is not having any seizures, so prophylactic anti-epileptic drugs should be avoided. So if
Thank you so much for that information. And I think this is also applicable to the other brain metastases, to not start any anti-epileptic if the patient's not got seizures, especially when the patient just has cerebellar metastasis. Coming to the further investigations.
So a core biopsy was done, which revealed invasive breast cancer, NST grade 3, ER4 plus, PR and HER2 negative. So the further question of the need for further metastatic workup and the optimum metastatic workup.
So at this crossroads, we were discussing with the patient about the options of MTP. And for all the clinical oncologists over here, Dr. Punita Lal, can you weigh in on how difficult these discussions are with a young patient she's a primey. This was her first pregnancy.
Thank you, Rima. Yes, it's naturally going to be extremely difficult discussion because she's, let's put it from a radiation oncologist perspective, she's a first trimester and she's locally, she's not, she's early disease, but she has brain metastasis, which makes her the median survival obviously drops down to say about 6 months if treated properly. So it is an extremely difficult discussion, and one would, from our point of view, if we look at, because radiation has long-term effects on not only the mother but also on the fetus, and that is what is bothering us. So we would say that when the pregnant woman comes to us, for us, we always try to see what phase she is falling into. If she's into the early phase, like before 11 weeks or before, then she's into the organogenesis phase of the fetus, which means that if we give radiation at this point in time, then we can expect severe structural organic organ formation abnormalities at a later date for the fetus, and that should not be very sort of acceptable. So we have to talk it out with the family and the patient regarding the long-term effects that can be there, simply because the fetus is very small at this point and organogenesis is going on. That is regarding the counseling part of it. And
so, madam, just interjecting once over here.
Yes.
Would it be easier for you to deliver whole brain radiation or any sort of brain radiation to a patient when she is in her first trimester versus her last trimester? considering that the distance between her fetus and the brain actually reduces with progressing pregnancy. So wouldn't it be more challenging, and wouldn't the fetal radiation doses be higher if she was in her last trimester versus in her first trimester? Because there are certain reports of safely being able to deliver radiation, at least to the brain. I'm not talking about breast radiation or a chest wall radiation, but at least to the brain. In such situation, I mean, in a rare situation, despite being metastatic, if a mother wants to continue with her pregnancy,
Yes.
then
So
in that case, can
that
we still go ahead? Yeah.
but we will really have to explain it out
Correct.
because see, while the distance between the brain and the uterus would be more, but still there is some backscatter radiation which would reach the uterus, which we cannot avoid. And we do not know what the long-term repercussions of such even a small scatter, which is to the tune of, say, less than, to the tune of under 3%. But
Correct.
that we will never be able to avoid.
So there are small series who've done something like this, and they have described leukemias in the children subsequently because of the low dose radiation that the embryo or the fetus received. So thank you for bringing up this wonderful point over here. And so we will just move on with the case further. So she did undergo an MTP. And I think, Shalaka, you were a part of all this discussion with the patient, and a lot of senior faculty was discussing with the patient about the options. So even though it looked like she had solitary brain lesion, she did opt for, and because even though she was a primary, she did opt for a MTP. So our problem and our uniqueness does not end there. She's again a patient with oligometastatic disease, which is also an uncommon thing to happen in any breast cancer patient, and even more so uncommon in a pregnancy-associated breast cancer. So Dr. Sneha, I would like you to weigh in about brain imaging on PET.
Like I mentioned earlier, PET-CT is not the imaging of choice for evaluating brain mets because of the intense uptake of FDG in normal brain. But lesions as large as these would surely show uptake, and hence you can use FDG PET to evaluate this. But having said that, if you're not sure that there are brain mets, then PET-CT should not be the modality for evaluating brain.
And how fast or how soon after the MTP can you do a PET-CT scan?
There is no, there, yeah, you can do it, you can do it. You can do it immediately. There are no restrictions.
Okay. Thank you so much. What is the management that you're thinking over here with this patient?
So I would definitely ask for if there is possibility of craniotomy and trying to remove this tumor physically, surgically, that would be, of course, ideal. But if it is not feasible for whatever reasons, then we can now, since she has undergone MTP, she can always go for a stereotactic kind of a surgery, or she can go for radiotherapy to the whole brain. So that can be tackled if we are talking about this lesion. And as and when the chemotherapy plan comes, we can always choose molecules which also cross blood-brain barrier. Kind of planning can be done.
Okay. So, Shalaka, are you also on page with the same thing?
Rima, I was assessing this patient in the diplopia, and we had an ophthal evaluation for her. There was a decreasing vision also on the same side. So that was of immediate concern to us. And like you said, she has had an MTP, so there would be no anesthesia risk of any kind of surgery now anymore. So she did undergo, and she has localizing signs. She has diplopia, she has midline shift. And I'm
sure papilledema also, actually.
I'm sure you can take care of this probably by SRS, SBRT, but she did undergo neurosurgery for all these factors for immediate rapid control or decompression of symptoms. And her vision did improve slightly after that, if I remember correctly. So I would recommend rather neurosurgery at this point, follow that with radiation, obviously, and chemotherapy, and then come to the breast a little later for the breast.
So Dr. Punita, would you also agree on this, or would you have a different take being a radiation oncologist? Do you think a whole brain should have been done, SRS, SRT?
Yeah, so one thing, if the surgeon operates, then we would like to give radiation to this area. That would be better. But in case, for whatever reason, the surgeon is not able to operate, and it is an oligometastasis, fairly largish, I would say, for 4 centimeters, but still should be amenable to stereotactic radiotherapy. Having said that, if we just go ahead with SRT, and then we need to monitor it time and again. Whole brain, if we were to give, because there's a good 40% chance or 50% chance that there would be shield throw recurrence anywhere elsewhere in the brain. So giving stereotactic radiotherapy to the primary, to the site which is there, which is seen, and a whole brain would be a safer option as far as an old timer like me would be concerned. Although there are studies which are now pushing the fact that we go ahead with MR scans as follow up every 3 months, and then just do SRT to that area.
Right.
So there are two schools of thoughts.
Correct. Thank you for bringing the old school as well in. I thought we had a very, very young panel. Everyone was aggressive and only voted for SRS and SRTs. But yes, whole brain becomes an option when all of these adverse features come in together. Just wanted to again clarify, because she also has a midline shift and she was extremely symptomatic, deteriorating by the day. We did consider for a craniotomy. She was planned for whole brain radiation to try and reduce the time between her RT and chemotherapy and sort of expedite everything. But ultimately, she had to undergo craniotomy and radiation after that. Now, bringing in after craniotomy, so I'm glad everyone's voted for the intention of therapy is radical because of solitary brain metastasis, and I'm thankful that everyone considers that radical treatment should be given for oligometastatic patients. We don't have, even our old timers actually think that, and I'm happy about that. Coming to locoregional therapy with oligometastatic disease. So we've already discussed a part of this, saying that we would rather have metastasectomy in such a patient and follow it up with RT. We have contemporary series, the old series, all of them saying that just craniotomy and metastasectomy is not enough. We have to add it up with radiation. So even if she was a lady who would have considered pregnancy and who would have carried her gestation forward, we would have had to give her radiation of some sort. And just doing a metastasectomy would not have been enough. Yes, Shalaka, you want to add?
Rima, I have a question. I know I'm not supposed to ask questions to you, but to all the radiation oncologists, essentially, if we were not to do MTP on her, and we had done a craniotomy and we had operated in, maybe she's 10 weeks, waiting for 2 weeks wouldn't be too bad. And then we would have done a craniotomy and resection of that decompression of the tumor. Then would you be okay waiting for her to deliver to give the radiation, or would you want to give the radiation when she's pregnant?
We would not have been. That is exactly the point I made before you sort of interjected, that we would not have been okay waiting on her for a few months before she would get her cranial radiation. There are contemporary series as well as series from Patchell that say that you will have to add radiotherapy. For those where radiotherapy was not added after metastasectomy, they will fare worse. And there is a high chance of having the disease come back in the same tumor bed.
So how soon? That's what I meant. If you could tide over with chemo and give it later, would be okay.
So the median time to disease recurrence or intracranial failure would be very short, would be less than 6 months in such a patient. So again, it's not a suitable or a ideal option.
And to nail
now, coming to brain surgery in the same sitting,
radiation while just taking a message while she's pregnant to the brain.
I couldn't hear you, Shalaka.
I said the message for giving radiation to the brain while she's pregnant.
Yes, so that is what I think Dr. Punita and I discussed, that worse comes to worse in a situation like this, we will go ahead with the radiation, considering the risk, that the patient understands the risk to the child, the risk to the fetus, and then goes ahead with progressing with her pregnancy. So all of these discussions have to be taken before we take the management decisions of even going ahead and doing the surgery. So quickly, Shalaka, again coming to you, breast surgery in the same sitting, would you do it as the craniotomy or would you want to delay it?
I would want to delay it. We could do it because she seems to be early breast cancer, and we could probably then stage her axilla better. But I'm tempted to give her chemotherapy after the brain surgery and radiation is done, and let the tumor shrink down. Let the effect of systemic therapy also, because she's metastatic to begin with, oligometastatic, let that effect also help her. She's 4+negative. She would benefit with chemotherapy surely, either before surgery or after surgery. I'm tempted to give her chemotherapy before surgery.
Now, coming to the medical oncologist, she's a lady who is fresh from a craniotomy. Your radiation oncologist is pushing for radiation. You are pushing for chemotherapy. How do we settle this? So anyone can we have? Yes, great. We have a medical oncologist.
Yeah. And for me,
neurosurgery has been done, so I think we can wait for. We can start with the chemotherapy as well, and radiotherapy can be done like.
Dr. Atul, it is between you and me. So should I start my radiation first, or you would want to do your chemo first?
I would actually like to start chemotherapy first. We've seen that this is an aggressive tumor, and we need to get in systemic therapy. This is almost like a triple-negative breast cancer, and now neurosurgery has already been done. So I think waiting for radiotherapy probably can be sandwiched sometime in between after starting chemotherapy as well. And I would actually push towards starting chemotherapy at this point. Get a genetic workup done, and
right. Dr. Punita, if you can come in on this as well.
Yeah. So, one would like to bring in, it's not like giving radiation in a normal course to the breast that you wait and then you take in all the chemotherapy and then go ahead with the. Here, we would like to push radiation at least to the brain as early as possible. So maybe the advantage of what Dr. Atul and all can do is that immediately after brain surgery, they can go ahead with 1 or 2 cycles and then we put in, we give radiotherapy. We can't wait for long. That is what the.
So I just wanted you to bring in the point. Is it necessary to wait after a craniotomy for RT?
Not really. Not really.
Actually, there is some evidence to this, madam, that we have something called as cavity dynamics. In a patient who had a 4 centimeter or a largish lesion, the tumor bed size and shape changes over the 4 to 6 weeks period. And
we request you to conclude.
Some studies that have shown that it is wiser. Sure, it's wiser to wait for at least 4 weeks before you finalize your target volumes, so that your target volumes also actually go down and your rest of the brain receiving unnecessary radiation doses, especially during a cavity SRT sort of treatment, minimizes. So as such, we would have had to wait for 4 weeks, and which is why I think we also took a decision to go ahead and do a cycle of chemotherapy.
Rima,
so
can I
chemotherapies before?
Rima, can you just quickly wind it up because getting messages from the organizers that we are, running late, please. Just the key points.
So the key point over here was that we did sandwich the chemotherapy and radiation for this particular patient. And because we were doing concurrent sort of chemo radiation, we requested the medical oncologist to rather start with paclitaxel rather than starting with anthracycline, so that we could safely deliver the radiation to this particular patient. This is how our plan looked. We did cavity SRT. The doses were slightly lower than our conventional SRT doses, and that was considering the fact the size of the cavity was quite large, and also the fact that we were giving concurrent chemotherapy. So it's sort of biologically optimized in that manner. And then further management, she underwent more chemotherapy. Just wanted the medical oncologist to say if they would want to give the same paclitaxel and anthracycline chemotherapy, or they would like to give any other biological agents, because these are more triple negative, more TILs, any immunotherapy coming in.
If she was HER2 positive, trastuzumab would have been allowed. Immunotherapy, we don't have a data in pregnant patients if it was triple negative. And this using taxane and the standard protocols is perfectly fine as long as it is beyond first trimester. But in our case, she is hormone positive, so we would like to start hormone only at the end of pregnancy, means after she has delivered. And we have to manage with chemotherapy, standard protocols. And I think taxane, as you said, it allowed radiotherapy to be given safely without harming with the anthracyclines, and also cardiopulmonary compromise of the fetus is also prevented if we avoid anthracyclines. So it's a very good idea to start with the taxane first, and later at the end of later in the trimester or after delivery, we can always deliver anthracycline based.
Thank you so much. So
I really request Rima. I think it is a
we are done.
intense discussion.
Yeah.
But we have to really sum up.
Because yes, so I think Sir can sort of bring in the take-home points. We've discussed.
No, I think you just. I mean, I don't want to spend more time. You just in one sentence finish it off. I think.
So I think the message was loud and clear. For pregnancy-associated breast cancers, you will manage it the way you would manage any other breast cancer, keeping in mind which trimester she is in. For oligometastatic disease, most of us weighed in and said that radical treatment should be done for a patient, even though she was pregnancy-associated, and even though she had a more aggressive biology of the disease. And at the end of the day, the discussion regarding treatment with radiotherapy and with surgery and chemotherapy has to be weighed in based on the trimester the patient is in. And at every step in time, a multidisciplinary team has to talk to the patient about the risks and the benefits of all the management options and the option of whether she wants to continue her gestation or not.
Okay, I think well summarized.
Thank you so much.
So we'll
yes.
conclude.
Thank
so
you.
Jyoti,
Thank you.